Okay, so, oh, there's Amber. Okay, so we'll go over the study guides, and if you have any questions, please ask. And I apologize, my dog's outside, if you can hear that. Vicious, isn't he? That whole 2.5 pounds of him will tear you up. Okay, and he's like the one that barks the most out of all of them. Okay, so what common virus causes rheumatic fever?
Strep.
Strep throat.
Yeah, strep throat. Definitely strep throat. And what's the blood test that we use to confirm?
ASO.
And the ASO titer, right? Let me see. What are some signs and symptoms of rheumatic fever?
Fever, arthritis, Aschoff nodules, valvulitis.
How can you tell they have valvulitis? What do you think?
Whoosh, swish, and a gurgle.
Yep, that's it. So you're going to hear some murmuring going on. What's the Ashkoff bodies? Would we see them? And if we would see them, where would we see them at? Anybody? What do you think?
Isn't it changes in like the connective tissue in your lymphocytes and things?
Yeah, so you really wouldn't see them. Okay.
So what are the other symptoms of that besides like valvulitis and Ashkoff's and fever?
What else do you think? Anybody?
Pericarditis, erythema marginatum,
Okay, what's erythema marginatum?
red spots.
Red spots on the back. They kind of reminds me almost like a tick bite because it's the red spots and then inside those red, that marginum. The marginum is red, but the inside is kind of like palish. So that's a definite go-to if they have that. They're gonna feel fatigued, you know, probably a little bit of chest pain if it's gotten as far as pericarditis. They're gonna feel like crap. Okay. So what a patient that comes in and feeling like crap, what are we gonna do? They have their erythema margitum, they have the arthritis, the malaise, and they're like, I just feel like horrid. What kind of questions do you think you should ask them?
If they've ever had strep throat before.
Yeah. You don't even have to say strep if they've had a sore throat recently. Like they can get that rheumatic fever within like a month, 2 months of having strep throat. So, one of the questions, have you had a sore throat lately? And then they could say, well, yeah, matter of fact, I got me a strep throat a couple months ago, and that would really define our diagnosis.
Can they have this even if they got strep throat and they were never on an antibiotic for it? Because you said something about not finishing the antibiotic.
They could. So
Okay.
It's the same bacteria as strep throat. And so what happens though, most people get what? They have strep throat, they feel like crap, their throat hurts. So what do? They go to the doctor goes, yep, you have strep throat, and they start taking antibiotics. Then they start feeling well, right? And when they start feeling well, what do you mainly do whenever you start feeling good? What happens to your antibiotics?
You forget to take them.
Yeah, you don't take them. And so it kills it enough, but then it can mutate into rheumatic fever. on a person that doesn't go to the doctor for strep throat, which I find very hard to find anybody like that, because usually it hurts that you can't drink or anything. It's still the same bacteria. It overgrows and can turn into rheumatic fever. Okay. Now, it's easier, I would say, not easier, but it's easy not to take all those antibiotics, isn't it? If you have a child, anybody that has children, and your 4-year-old sitting there complaining about sore throat, or your 7-year-old or 10-year-old, oh, I have a sore throat, and then you're giving those antibiotics, then they're not complaining anymore, and then you forget about those antibiotics. On the same aspect, like my 15-year-old will complain about a sore throat, and then did you take them? Uh-huh. Did you take those antibiotics? Uh-huh. Till I count them, and then I find out that she didn't take them. Think I'm that stupid? Anyway, so that's why 5 to 15 years of age is the prime age of not, finishing those antibiotics and possibly getting the rheumatic fever.
So Becky, if they
yeah.
didn't have strep, but they were on antibiotic therapy for something else, that couldn't cause it if they didn't take the antibiotics for that, right? It would
Well,
only be if it's for strep.
Yeah, because that's the bacteria that causes the rheumatic fever. Is the streptococcus. So like if they had, let's say, MRSA of a wound, they won't get rheumatic fever from that. Okay. So I guess I covered what the patient teaching to help prevent rheumatic fever is, huh? I should just shut my mouth. So finish all your antibiotics, right? Whether you like it or not, finish your antibiotics out. And I don't know about you, but I have some antibiotics in there that I probably should throw out. But I don't know. Maybe I should just do that someday. Some weekend will be a good time. Let's see. What diagnosis test would you use to diagnose rheumatic fever?
Throat culture.
Throat culture. That's definitely one way.
ESR. ESR.
Yeah, ESR.
CRP.
Yep, those are all showing inflammation.
And CBC.
CBC. Very good.
Would the ASO titer be on that too, or just for the?
You can do
Okay.
an ESO titer because it will show that they had strep throat, and that puts you more towards it. And I already talked to you about what questions would you ask the patient to help determine if they have rheumatic fever, because I can't shut my mouth. What is the pericardium?
Sac
It's
around
the
the
sac
heart.
that the heart sits in.
Yep, the sac the heart sits in. Before we go further, is there any more questions about rheumatic fever? How do you feel? Generally, it's all about prevention. Oh, wait, I know what I can ask. Hold on, forget about the pericardium. Why is rheumatic fever such a problem? Why are we talking about it in cardio class? Shouldn't it be like in Tessa's class?
Because it affects the layers of the heart. It can affect the layers of the heart.
Yeah. And when we're talking about in older age, further down the years, what do we find to be a problem with people that have rheumatic fever?
They'll have valve problems.
Yes, they'll have valve problems. So it's real important for us to know rheumatic fever because it damages the valves. And if it damages the valves, what can happen is that they could end up with ineffective endocarditis. They can end up with myocarditis. Basically, they can end up with infections of the heart. So that's why when people have rheumatic rheumatic fever, if they have a history, no matter what, if they go to the dentist, if they go and get a colonoscopy, if they go and have a baby, we're going to start giving them antibiotics. Okay, to prevent any kind of infection of the heart. Because what happens is the heart gets scarred from rheumatic fever, the valves get scarred, and so bacteria can grab onto that scarring tissue and procreate. You figure they have everything they need to procreate around the heart. They have oxygen, they have food, they're good to go. So that's why we give them prophylactic, so that the bacteria doesn't get to the heart and start procreating in the heart. Does that make sense? So when we see somebody with rheumatic fever, we're very concerned about that aspect. Okay, back to the pericardium. So pericardium is the sac around the heart. What are some?
I had a question.
Oh,
So the ASO, sorry, the ASO titer is the only is that the only test that we do to verify the virus? I can't get my dang screen to move. The question number 2.
Yeah.
What blood test is that the only one? Because it was like CBC and all of that too on that paper for
Right, there's
diagnostics.
CBC, but that's the one that points us towards the them having strep. So
Okay.
we could use CBC, we can use the ESR and the CRP to show inflammation, but the definitive would say that it is rheumatic heart disease or rheumatic fever is the ASO titer, because that says
Okay.
strep. That's where we are testing for strep. Streptococcus
Okay.
bacteria.
Okay.
I like how I said no questions, and you're like,
You know I'm gonna ask anyway.
I know. Okay, so what are some signs and symptoms of pericarditis?
Sharp, abrupt onset of chest pain that may radiate to the neck or back.
Okay,
Pain aggravated by respiratory movements or change in position.
okay,
Low-grade fever.
yep,
And pain relieved by sitting forward.
yes. That's a big one. It's gonna hurt, but if you see that it feels better leaning forward, then we're looking at pericarditis.
Doesn't the pericardial friction rub go with that too?
Yes. You might hear it, you might not hear it. It depends on how far they are. So yeah, those are all real good descriptions of the signs and symptoms. So what is a pericardial rub? Well, it's basically, it sounds like something rubbing, like I can't.
Is that like when the heart and something like rubs against each other to?
Yes, because what happens is you have the pericardium and you have the layer, right? And when that one in between, you have that serous fluid, and when it gets inflamed, it's not able to rub like it should. It should glide over each other. Well, it can't glide. So whenever it can't glide, then that's where you get your pain from. Okay. So that's where you also hear that friction rub. Is it a complication? Is the friction rub a complication? No, it's a symptom of pericarditis. What are some of the diagnostic tools we would use for pericarditis?
CKMB and troponins.
Okay, why troponins?
To see if they had any damage to the heart.
Could be. There might be another reason why we might throw troponins in there.
To roll out an MI?
Yeah, to roll out an MI. Okay, so you would see troponins. Anybody comes in with chest pain, we're going to go right for that MI, right? Because everybody's going to die on us. So we have to do that MI. What are the troponins? What else what would we do?
A chest x-ray.
Chest x-ray. And do you think the chest x-ray is really going to show pericarditis?
No.
Why do we do the chest x-ray?
For inflammation, I don't know.
Well,
I don't know.
what do you guys think?
Pneumonia.
Yeah, we could roll out. That's another rollout. While we're rolling out the chest x-ray and the troponins, what else are we going to do?
Echo.
Echo.
EKG.
Yeah, EKG is going to roll it out too. Did you understand where it says diffuse? if you looked on the PowerPoint, it showed the QRS is really small. Now think about it, whenever you're doing an EKG, you're measuring the electrical impulses of the heart, right? Well, if it has to go through fluid or pus or, whatever is going on with the pericarditis, it's going to be diffuse. It's not going to be as loud, so to speak. So the EKG is not going to be able to pick it up as much. That's why it has smaller diffuse QRSs and the Ts. Okay. Does that make sense? Okay. So we would use all those for diagnostics. Okay. It states that the EKG may show diffuse ST elevation in all leads. QRS may be decreased. Oh, you know what? I'm just going to stop my talking before I answer these, before I look at the questions. And the reason why, even though it may show diffuse, the reason we do it is to rule out anything else. Okay. What is the treatment for uncomplicated pericarditis?
Tylenol, NSAIDs, and steroids in some cases.
Okay. That sounds about right, right? Okay, so why don't we use antibiotics?
Because it's not a bacteria, it's an injury.
Right. So whenever we're talking about it, when we talk about pericarditis, it's going to be more inflammation, but not infection. Okay, so if it's inflammation, we're going to use things that will decrease the inflammation. Remember, when we talk about pericarditis, it's inflammation, not infection. Okay. So we're going to just basically do things to decrease the inflammation. So if you have this patient with pericarditis and they're saying, oh, my chest hurts. Oh, give me something. And you look on give me something. I want something. Just give me something to take care of this pain. Oh, the pain. And you look on your MAR and you have Norco, morphine, or ibuprofen. Which would take care of that patient?
Ibuprofen.
Why?
Because it's an anti-inflammatory.
Exactly. So in this case, okay, when you have inflammation that's causing the pain, you want to get rid of the inflammation and that will take care of the pain.
Do we ever give an analgesic with that?
You can. Because there is what's it called? There is what is it called? It's like hydro, and basically it's hydrocodone with an NSAID.
Tylenol?
No, it's not. It's like a hydrocodone and ibuprofen. Hydroprofen is what it's called.
Yeah.
So you can, but they don't give it up very easily. Like, for whatever reason, I've asked a couple of farm doctors of pharmacy why they don't do that. Because isn't that perfect? You take away the inflammation and you give them pain relief. And for whatever reason, it could be because of GI complications. I don't know why, but they don't do that. Could you give like a Toradol and a Norco? You can. But Tanisha had a patient last week that had ineffective encarditis, and they gave her Toradol. They finally got her to order Toradol, and Tanisha, she never had Dilaudid after that. She just wanted the Toradol because the Toradol works so much better for her than Dilaudid.
Well, she said that, so
yeah, and
that made me feel like she wasn't drug seeking after she said that.
No, because I don't know many crackheads that like Toradol. Give me the Toradol, man.
Right.
So, I mean, and because I went to work the next day and I was doing chart audits, and she still, all she had was the Toradol. So the Toradol does work. Okay, so you just might see a question somewhere about that, what to use for those kind of patients. Okay, so what is considered complicated pericarditis?
Excessive fluid.
Excessive fluid. And if we have excessive fluid, what's going to happen to the heart?
It won't be able to contract.
Right. It won't be able to beat. It won't be able to contract. So you're going to have your pericardium and your little heart like this. And with that fluid that keeps on accumulating, it's basically going to end up suffocating the heart. So it's unable to beat. So what we have to do is we have to go in and relieve that fluid. And how do we relieve that fluid?
Pericardiocentesis.
Yes, that's one way.
Pericardial window.
Okay, so pericardiocentesis, which we've seen on any doctor show in the world, Grey's Anatomy, ER, they go in there, and pull the fluid out, right? Sight unseen, not a problem. They can do it. It's not as much dramatic as that. Usually we use an ultrasound so we're not puncturing anything, but it's kind of cool because you can see when you puncture the pericardium that the heart reacts on the EKG. So if they really wanted to, they could just use an EKG machine. And then a pericardial window, and what that does is we take part of the pericardium and we have a drain that will drain that fluid off that heart. Okay, so hold on, let me read my questions before I talk anymore. Aha.
Yeah, that was not,
What?
so that's the answer to number 19.
Yeah, shut up. Okay. Oh shit! I didn't even go to 19. I was shutting up before I went to 17. Okay. So
So is the excessive fluid around the heart, is that considered cardiac tamponade, or is it?
yes, that would be
Okay.
considered cardiac tamponade. So
Okay.
when you have that excess fluid, so so say you have a patient at 7 o'clock, and 7 o'clock in the morning, you listen to the apical pulse and you hear lub dub, everything's great. And then at 10 o'clock, you listen, and what you're going to hear is lub dub, a lot less. You're not going to hear it as much. That's when you can start suspecting that it's cardiac tamponade. Don't wait. It's not like a pedal pulse. You don't want to go and get your Doppler to see if you can find your cardiac, that you can hear the lub dub. Okay, if you are having a hard time listening to the lub dub, it's gone too far. Okay, you need to call the doctor and you need to get that patient down into surgery to relieve that. Okay.
So is the difference between pericarditis and the tamponade just the amount of fluid?
Yes.
What determine, I guess just the heart sounds? That's the thing that.
The heart sounds, okay, so if you have a patient that has pericarditis, they're going to be in pain. They're going to feel better. They're going to sit forward. What about, how do you think they can sit? You think they can lay flat?
Sit upright.
Yeah, they're going to have to be upright. When you talk about cardiac tamponade, so that's pericarditis gone haywire. So what signs and symptoms other than the heartbeat would you expect the patient to be showing? So if you walked into that patient's room, you can look and go, crap, something's going wrong.
Jugular vein distension.
Yes, they're going to have jugular vein distension. What else?
They might be altered
Altered? Why would they be altered?
because they're not getting enough oxygen and blood to the brain.
Right.
It's
They're
not beating that
getting
much.
Yeah, they're not getting enough oxygenated.
Would they be cyanotic?
They could be cyanotic. Okay, and that's without even listening to the heart. I tell you what, we had a nurse, we had a patient that had pericarditis on her floor, and this is how serious it was. She never listened to the heart rate of the heart at all. Never put her stethoscope to the heart. She got fired. Nothing happened to that patient, but by never listening to the heart, she put that patient at risk. So they fired her. I think she works at like Jumpin' Jimmy's or something. I don't know. I could be wrong. That's where she belongs.
So can we remove that fluid too fast?
Probably not. I would imagine. I imagine your heart would love you if you can get rid of that fluid. If you did a paracentesis, that they do that really quick. I wouldn't. So by that question, I'm wondering if you're like, if it can go into shock, so to speak, because you're removing the fluid. Remember that fluid's not on the heart itself, it's on the sac surrounding the heart. So the heart is gonna, so you're gonna take that fluid off and the heart's gonna be like happy. Okay, patient probably would be a little happy too. Quite
Can
honestly.
you explain a periocardicentesis just a little bit better? Like, is it like a syringe that they're
Yeah.
taking it out with?
So it's a
Okay.
needle about yay big, and it goes in. So they use an ultrasound and they go find, they're supposed to. But if you're on Grey's Anatomy and you're Dr. Gray or Dr. Anatomy, whoever.
McDreamy.
Oh, is that really his name on there?
Not his real
Yang
name,
would
but that's
be
what they
doing
call
anything
him.
with the heart, though. Like it would be Dr. Yang if it had to do with the heart.
What's his real name?
I don't know.
McDreamy, Derek
Derek
Shepherd,
Shepherd.
Derek Shepherd.
the
Okay. You're Derek
neurosurgeon.
Shepherd. You're going to go in and it's with a Toomey syringe. A Toomey syringe is 60 mLs. So you're going to go in there and, you know, if you're not Dr. McDreamy, if you're a regular doctor, you get an ultrasound, you find a pocket so that you don't hit the muscle of the heart, you just hear the pericardium. But I've seen enough episodes of doctors' movies, they just go in and then they pull out the fluid. And the fluid's usually is usually serous. Like there's no real color. It kind of looks like pee almost. Like I was kind of like, it's not tea colored. It's a little bit less than tea colored. But anyway, that's a pericardicentesis is. If somebody does it really quickly, it's because they have blood around the heart. So if they were in a car accident, that's a lot of times what they don't look at with the ultrasound is because they're in a car accident and it's like they have to get that fluid off now. So in that case, it could be blood and lymph at that point in time. Okay.
Actually, at work, we just flew out a lady she had pericarditis, but her complaint was anxiety. And so everyone was like blowing it off as anxiety and like restlessness until her SATs dropped to like 88%. And then we almost had to intubate, and then it was turning into cardiac tamponade by the time the cardiologist wanted her flown out. So it was pretty wild.
She wanted to prove you wrong.
Right. And she was only 35. So none of us were thinking anything,
So what caused it?
We don't know. We didn't get a call back or anything, but yeah.
So we had a patient, and I'll have to get my EKG strip out, but you can tell somebody's going in cardiac tamponade because the QRS is tall, and then the next one's short, and then the next one's tall, and the next one's short. And for whatever reason, that's cardiac tamponade. That's like perfect cardiac tamponade. So we had a patient that was going in cardiac tamponade. And oh my God, it was at 3209. It was in 3209 too, which I'm never going to take that room again. But the patient was in 3209 going in cardiac tamponade, and my student comes up and she's, yeah, she doesn't want to lay flat because she says it's harder for her to breathe. I'm like, really? That's good because I could see that because she's going into cardiac tamponade. And then a couple of weeks ago, in the last semester, they were having a patient and Christy Hodge threw me the EKG and she goes, what does that look like to you? I'm like, well, that looks like cardiac tamponade. And she's like, nuh-uh. I'm like, it's cardiac tamponade. I'm telling you that patient's going to cardiac tamponade. And she's like, no, she goes, what do you think it is? I'm like, it's cardiac tamponade. I'm telling you. Wouldn't you know, she got back the CT and it showed pleural effusions. Not pleural effusion, pericardial infusions. And I'm like, anyway, that was my dance. Anyway, okay. And we talked about the heart failure. So the patient's going to be going through heart failure basically at this point in time. If we don't get that, taken care of. What are some causes of myocarditis? There's all kinds of causes, right?
Radiation.
Radiation. Basically, it's anything that hurts the heart. Now, why is myocarditis so totally different from pericarditis?
Because it's an infection, not an injury.
Okay.
It's the heart muscle, not the surrounding sac.
Yeah, it's so we're talking of the big daddy. We're talking about heart muscle. Okay. So anything that would damage that heart muscle. So it could be anything from radiation to, I always say, car accidents. Let's say ATV accidents. Okay. Could it be bacteria? Could bacteria cause it? What do you think?
Yes.
Could possibly do it. Or viral, could be viral problems. So what kind of treatment do we use when we're talking about myocarditis?
Antimicrobial therapy.
Yep, definitely. Now, could a patient?
I didn't hear that. What's that?
Antibiotics. Okay, so could a patient, well, I can't even think of a good scenario, but let me just tell you this. Remember, if a patient gets injured and they have dead cells, those dead cells could grow bacteria on them. Okay, so like with radiation or a ATV accident, if the heart gets injured and that part has bleeding or damaged cells, it's kind of like, it can grow bacteria on those damaged cells. So even though it started as an ATV, we'd still probably give them some antibiotic therapy due to the fact that it could get worse. Does that make sense?
So how would an infection develop if it wasn't, like, if there's not a bacteria or something that comes in contact with it just from trauma? How would that cause it?
So just because it's dead cells. So think about, let me think of a good example. Think of a patient. I'm thinking like of a patient that has a hematoma. Hold on, I'm going to think of a good one, Alexa. I'm thinking of something that has a patient that has an injury, and because of the dead cells, God, I can't come up with a really good one.
So it's just that, like, the dead cells can develop an infection.
Well, so if you think about whenever something dies, when cells die, they release gosh. My biggest one that I think of is whenever somebody has a hematoma. So they have a deep tissue injury, okay? what happens with that blood? Well, the blood is dead. It causes injury and there's a pocket of blood. That pocket of blood can grow bacteria in it, right? Because that's the natural form of things. If somebody's immunity is low and the white cells don't come, the phagocytes don't come and eat away at that dead tissue, what's going to happen? But it can grow because of the decomposition. Does that make sense? Like when something dies, decomposition. If your body doesn't take care of it and carry away the dead part of it, the dead cells of it, then it can cause, the bacteria can grow from it, because that's the natural, let's face it, that's how nature works. When something dies, bacteria can grow from it, or how we could eat whatever we wanted when it got bad. Does that make any sense? I can't think of it. I will come up with a better solution.
Yeah, I get it.
I'm just not able to articulate it at this point in time. So, gosh, I don't even know where I'm at. Okay, so we can do antibiotics. What kind of activity is going to be for this patient?
Bed rest,
Why?
because otherwise it's gonna cause the need for more oxygen, and we don't want that.
Right. This is the one time where we're going to sit there and say bed rest is best for our patient. Okay, because if they get up to go to the bathroom, they're going to be in more pain. There's going to be more oxygen needed in that heart. And at this point in time, the heart can't handle it. Does that make sense? So we're going to decrease the oxygen need of the patient. Who made this study guide so freaking long? Okay. Yeah, that would be me. What is the inflammation of the endocardium?
Endocarditis.
Right. What kind of, don't we put something in front of that?
Infective endocarditis.
Ineffective endocarditis. I had to switch it around so you guys would be like, what does she mean by that? So you had to go dig in, hopefully. Who is at greatest risk for this disorder?
Drug users,
I know.
IV drug users.
I feel so bad. I feel bad for picking on them. But okay, so, and that's what happened with Tenasha's patient. She was an IV drug user, and she said she stopped using like 2 months prior. And we're like, yeah, But anyway, her original diagnosis was a UTI, and as far as we were considered, we were given Dilaudid for a UTI. And I'm like, well, gee, I don't know why we have an opioid epidemic given Dilaudid to UTIs. Sign me up. And no, just kidding, because I don't like how it makes me feel. But anyway, so we were kind of like, and then I started really reading into her chart, and I said, oh, it's because she has ineffective endocarditis. Now, she didn't have any of the real signs and symptoms of ineffective endocarditis, except for really the pain. So I mean, how does it happen? Oh, I can't do that because that's the number 26. Okay, so IV drug users, who else is that in could get ineffective endocarditis?
Patients with prior heart damage.
It could be valvular damage, but heart damage.
Valve prosthesis.
Valve prosthesis. What else do we got?
Dialysis patients.
Dialysis patients are really big risk.
Why is that? I didn't understand why that was.
So, okay, so that goes into number 26. Generally, how does the bacteria get to the heart?
When there's a pathway for it to be to get to the heart. So like IV drug users, because they're directly injecting into their arm, it will travel through their bloodstream to get there.
Right. So, Jessica, why do you think hemodialysis patients can get it?
I'm guessing when it's like going through all of the tubing and stuff, then it can go back into their body and go to the heart.
Right. So even if it as sterile as we try to make it, nothing's 100% sterile, right? So even getting accessing their the grafts, that's a highway to the heart. So just think of it any way you can get bacteria, the highway to the heart. Okay. So HD patients, IV drug users, patients that just had a cath. I mean, that's a perfect highway to the heart, right? But don't go so far as to like a diabetic patient that stubbed their toe and now they have an infection. Okay, because that's not really a highway. Yeah, they have infection and could get into their bloodstream, but we're talking that goes into their veins right to their heart, or arteries and right to their heart. A patient that has open heart surgery, a patient that has a colonoscopy, okay, anything that gets a highway to the heart.
PICC line.
PICC line, perfect example is a PICC line. So there was, I'm an ER, I love ER. So there was an incident on ER that happened at a concert, and this girl came in. Anybody watch ER? Oh my gosh, The Lost Generation.
We're a Grey's Anatomy generation.
You guys.
I got you. I watched ER. I'm with you.
Okay, thank you. So, so Carter was supposed to be not even on, which he was the doctor. Anyway, not as cute as Dr. McDreamy, but anyway. And this girl kept on complaining about pain, and then she was complaining about having a hard time breathing, but she felt better when she sat forward a little bit. And then he listened to her chest and and he goes, he started asking her questions, and he goes, I think you have ineffective endocarditis. So he put her in a wheelchair and wheels her right into a room. And this was so funny because we just got done talking about it like 2 days prior of the one semester. And he goes, he's like, have you had, do you use drugs, IV drugs? She's like, no. Do you do this? No. And he goes, well, somehow you had to have bacteria get to your heart. And her friend goes, well, why don't you tell about the piercing? And he's like, what piercing? And she turns around and she got something pierced down there. And she got it at a tattoo shop, and they weren't very sterile about it, and it got infected. So the way she got her infective endocarditis is the fact that she had an infected piercing. I thought it was funny, but anyway. Carter was like, whoa, didn't need to see that. But anyway. And there was another one that was just happened on The Good Doctor. They had an infective endocarditis. But the thing is, just think about it as a bacteria highway to the heart. What are the manifestations of this condition? What would we see? What is it?
Fever and flu-like symptoms.
Okay, they feel like crap.
Cough, dyspnea, joint pain, heart murmurs.
Okay. What other ones?
The peripheral manifestations.
Oh, what are the peripheral manifestations?
Petechiae, splinter hemorrhages, Osler's nodes, Janeway lesions, Roth spots.
Okay, so the Roth spots we're not going to be able to see. Hence, because it's in the eyes. Okay, but what about Osler nodes? What are those?
Is that like a bruise, like in the joint area or something?
Yeah, is it painful?
It's tender.
It can be tender. Okay, so what's the difference between that and the
Janeway.
yeah, Janeway lesions?
They're not painful, usually on the palms.
Yes, those are on the palms and not painful. What are splinter hemorrhages?
like little bruises underneath the fingernails.
Yeah, it reminds me a lot of like the petechiae, but it's underneath the fingernails. Okay. How do we treat infective encarditis?
Specific antibiotics, usually penicillin.
Okay. And are those IV or PO?
IV.
Okay. So what's a big problem?
You need a
Needs to be
pick.
long-term.
It has to be long term. And then what creates a bigger problem?
The
They
straight
may have to
highway.
go home with like a pick or something. I'm
Yeah.
sorry, Alexa. You can.
So if the patient goes home and they're an IV drug user, how are we going to do that with a PICC line? They would love us. Okay. Because they would have that IV, they would have that PICC line and they have total access. So it's a real ethical problem with these folks. What are we going to do with them? Do we, there was a hospital in Minnesota that had a contract. They had a patient sign a contract saying they would not use their PICC line for IV drug use. Well, guess how that worked out? I mean,
IV drug users are so truthful. They don't lie ever.
that's a good way to put it. Yeah. Yeah. I would, and I liken it to that, in psych, when you have the contract to not kill yourself, well, if you sign this contract, you can go home. Just promise don't kill yourself. Yeah, like that contract really works, right? They'll say anything to get out. Well, and that's the problem. A place in Minnesota, the hospital in Minnesota, sent the patient home with a PICC line saying that, she's not going to use it. Well, within like 48 hours, she was dead. And then the family sued the hospital because the hospital should have known better. But it's a toss up. How do you treat these folks when it has to be IV? It can't go through the digestive system. It has to go IV to get to the bacteria at the heart. So some people you might see that they go into long-term care, like a nursing home. But let's face it, that's not a really cool place to stay. So it's tough. And these guys, their veins aren't the best. They probably can hit them better than we can. Because they know exactly which vein works. So it's going to be hard to stick them depending on what kind of medication if they have to come to the hospital twice a day. That's going to be rough. So it's really rough situation with the infective encarditis.
Aren't there?
What?
Sorry, aren't there rehabilitation facilities where they could be inpatient?
They can be, but they have to want to. And then they have to have the insurance to be able to pay for that. And, I don't know how good of insurance they have, but I can imagine if it's the federal government's insurance, it's not, or the Illinois Medicaid system, I don't know if they'll want to pay. So it's a bad situation.
So is there a solution for this, or is it just kind of do the best that we can? And
We do the best we can. And then if we try to get the medication, so it's only daily. So if they have to come to the hospital, it's only daily. We try, and everybody's different. Like if they have to do it twice or 3 times a day, then we try to put them in a facility like a nursing home or something like that they can get it. But we don't leave, which would probably be better because they can leave that IV in a nursing facility. But usually they actually have to come back to the hospital, to the infusion center, to get it done. I think we sent somebody home. They were like 45 to a nursing home. I think they lasted like a week. Like I said, it's not a real cool place to be. I mean, it's cool if you work there and you have to live there, but I guess there's other places they'd rather be. Okay, so how are we going to prevent ineffective encarditis?
Good oral hygiene.
Good oral hygiene.
Scrub our IV ports.
Yes, scrub them.
Don't
What
do
about
drugs.
What was that?
Don't do drugs.
Don't do IV drugs.
Pre-med for dental appointments.
Yeah, so what patients would we give pre-meds for dental appointments? Should we just,
They've had rheumatic fever.
yes, so patients with
Dilantin.
rheumatic fever, and what other kind of patients? Which we're gonna talk about in the next study guide.
Anti-seizure medicine,
Anti-seizure.
like Dilantin. Dilantin does that, doesn't it? If you take that, you have. What am I thinking of?
I don't
I
know.
might be just going crazy.
Well,
When
there's-
I worked at a dental office, we pre-med all of our joint replacement patients. Is that a thing?
I don't know.
It was for the just to like prevent bacteria and stuff. But if they had joint replacement, they were always on a pre-med.
Really? I have to check that out.
This is
So-
the autoimmune disorder patients.
Yeah, autoimmune would be it. We also,
Patients on immunosuppressants.
yeah, because they definitely could contract it. We want to make sure anybody that has any kind of valvular issues that they have prophylactics. So if they have murmurs, okay, if they have mitral valve prolapse or any kind of valvular issues, we're going to make sure that they are prophylactic. Tanisha's patient was having regurgitation in her mitral valve. Unfortunately, it wasn't for us to hear. I would love to have everybody. I'm sure she would appreciate everybody coming in and listening to her heart, but I was gonna hopefully talk her into it. So any kind of valvular issues. Okay.
Do we need to know what antibiotic we would give for that?
No, because I would have put that on that study guide.
Okay, just making sure.
Yeah. Go away. I try to put everything on the study guide that you need to know. Okay, so I specifically left out the antibiotics because everybody's different. You know, every patient's different, so, and every doc is different. Okay, so are we good with that aspect of the study guides?
What was the answer to number 20?
Myocarditis.
Okay, thank you.
Wait, what is the inflammation of heart failure? What was I trying to say?
I didn't really know.
Or maybe I think what I was trying to say is, why would inflammation cause heart failure? That's probably where I was going with that.
Also, is myocarditis not? I put pericarditis.
It is pericarditis. Well, well, for number 20, what I was trying to say is, why would the inflammation cause heart failure? And it's because we're basically squishing it. We're squishing the heart. That's why it would cause the symptoms of heart failure.
So it is myocarditis.
No, well, no, number 20, I said it wrong. I was being Polish.
Oh.
So it said, what is the inflammation of heart failure? But what inflammation would cause heart failure? Something like that.
If you change heart failure to heart muscle, wouldn't it be the same though, like the inflammation of the heart
Maybe that's what I
muscle?
meant. Hell, I don't know what I meant anymore. What is the inflammation of heart muscle? That would be myocarditis. That sounds a little bit more reasonable. Boy, Alexa, you know me well.
So then the answer is myocarditis.
Yes.
Muscle.
Hey, you know, whenever you see these crappy ass, or I said ass.
Ooh.
Ooh, and I'm taping this. Okay, whenever you see like you're confused, you can email me and say, yo, what do you mean? And then I can figure it out. Okay, maybe I'll figure it out, or maybe I'll just send it to Alexa and she can figure it out. Either way, we'll figure it out. Okay. Okay,
Can you, what was the answer for 16? What are some of the signs and symptoms of complication for the pericardio,
pericarditis. So what are
no,
some,
pericardiocentesis? I thought that's what they were asking for.
okay, so what do we, so it's what do we do for complicated pericarditis, and what are some signs and symptoms of that complication? So it's basically, we're going to look for heart failure, and we're going to look for cardiac tamponade.
So would that be like the muffled heart sounds, dyspnea and all that?
Yes,
And that was the jugular vein distension too, right? That's what we talked about.
yes.
On 29, what were you trying to ask about? Lily, can you go out with that?
Explain the peripheral. So what are Janeway lesions? What's
Just those few at the bottom, the Janeway lesions, Osler nodes and Ross
Yes.
spots.
yes.
Okay.
Are we good? Okay, let's talk about valves. What are the two major heart valve disorders?
Stenosis and regurgitation.
Yep. And what's the difference between stenosis and regurgitation?
Stenosis is whenever the valve opening narrows and is rigid, and regurgitation is whenever it's like allows it to backflow.
Okay. Now, what is the most common valve disorder? Did you just shrug it?
Mitral valve.
Maybe.
What?
Mitral valve disorder.
Okay, but what kind of mitral valve disorder?
Prolapse.
Yes, the prolapse. See, I did it. I try to be a little sneaky, so you have to really look for it. Okay, what does mitral valve prolapse mean?
The mitral valve cuts below into the atrium during systole.
Right. And what does, I mean, so what does that mean? Look, Emily. So what does that mean? That it cusps into the atrium? What do you think?
It kind of falls into the atrium, doesn't come back.
Okay, so what does that matter?
Yes.
Why does it matter? What does that make it happen? What's the
Regurgitation.
yes, regurgitation. Very good, very good, very good. Okay. What would we do to a patient if they have, let's say, mitral valve prolapse, but they have they're asymptomatic? What are we gonna do?
Nothing.
Exactly. We wait until they have signs and symptoms. Okay. So if a person has a murmur, we don't do anything until they have problems. We don't do anything with their valvular problems or valvular disease until they have problems. What are some symptoms of valvular disease?
Fatigue and weakness.
So what would you consider that? Like, what does that mimic? Or wait, that might be a problem. Ugh, damn it. That was the number 7. Forget it. What else do you have? What other symptoms do you have?
Orthopnea, angina, palpitation, syncope.
Yep. Very good. So then we go to number 7. What do the worsening symptoms mimic? It's something that you had a quiz on last Thursday.
Right-sided heart failure.
Yes, with heart failure. Very good. I'm just happy with heart failure. So it's mimicking heart failure. So we're going to treat it. So we're going to expect to see the same symptoms as a heart failure patient. Okay, they're going to be dyspneic. What about peripheral pulses? What do you think that's going to happen with them?
Decrease.
Yeah, they're gonna be decreased. Because the heart's not, the blood's not coming out of the heart like it should, right? How do we diagnose valvular disorders?
An echo?
With what?
An echocardiogram?
Yeah, with an echocardiogram. Sorry. What? Yeah, with an echocardiogram. So we're gonna, that's like number one is how we're gonna look at the valves. We're gonna do we can do blood tests, and of course we're gonna do an EKG, and we're gonna see everything else, but the echo is the definitive factor. Okay, we can do, they can actually even do an angiogram to see, but the echo is where we're going. Why could there be a dysrhythmia because of this? Because of valve problems. And what dysrhythmia, so let's go this way. What dysrhythmias do you expect to see?
AFib maybe?
Yeah, AFib. Because that atrium is working, it ain't getting nowhere, right? Because as much as it's pushing and contracting, the blood is just coming right back into the, if it's a mitral valve, it's going into the left atrium. What else do you think you might have? Eventually, if we don't do anything about it. Would the ventricles eventually fail on us?
I was gonna say maybe VTAC or
Yeah.
VFib.
Eventually, we can go into VTAC or VFib. Due to the fact that there's not enough blood getting down and the cardiac output's low, so the ventricles are going to go, and eventually they're not going to be able to keep up anymore. Okay, so they'll go into VTAC, VFib. Why do you think a thrombus can form? Why is that a problem?
Because all the blood's not getting through.
Right, so it has a chance to coagulate. You know, you're only allowing so much blood to go through. It has actually a chance to coagulate. So a thrombus could happen with a patient like this. So how are we going to find out if they have a thrombus?
A D-dimer? Like a blood test?
I was thinking, TE, that's what I was looking for. So we would be able to see it on the echo on the front, and then we can do a TEE and look at the backside of the heart. So what kind of medications do you think they're going to be on if they do have a thrombus?
Anticoagulants.
Okay, like what?
Heparin.
Heparin.
Coumadin.
And what else?
Coumadin.
Coumadin. Coumadin, we're going to use that heparin, and what else to bridge over to Coumadin? Lovenox. Okay. I want to beat it into you guys the difference between an antiplatelet and an anticoagulant. So not beat. So I say beat, and I'm on Zoom and I'm recording it. I want you guys to know the difference. Okay. And I think we already answered these questions. Why would they receive prophylactic antibiotics? I'll answer it. Because of the damage of the valves, they're more likely to grab on. The bacteria is more able to grab on and procreate. Okay, I don't want to say procreate, but basically grab on and cause issues and cause infections. When would people with valvular disease get these antibiotics?
Before procedures,
What kind of procedures?
Dental.
dental work,
Yeah. What else?
Just invasive procedures.
Invasive. Well, you just took my wind out of my sails. So colonoscopies, any kind of cardiac caths, anything that could actually have enter bacteria into the vessels. Okay, we're going to make sure that we give them prophylactic antibiotics. What are 3 ways we could fix valvular disorders?
Surgery.
Well, that's like all of it. Need to be a little bit more specific.
Valve replacement.
Percutaneous,
Okay, valve replacement. What else?
percutaneous balloon valvuplasty.
Okay, valvuplasty. There's valvuplasty. There's just changing it all out. And there's repair, which a repair they can sometimes do in the cath lab also. Okay, so which one is the most invasive?
Valve replacement.
Yeah, the valve replacement, because it's like an open heart surgery. Okay, so you have to open the patient up, open their ribs up. So that's the most invasive. The valvuloplasty and the repair they can do in the cath lab, and they stay maybe a day and then they go home. Okay, so and a lot of times they're awake while they're doing it. So you want to make sure that we know that it's an open heart surgery. Okay, that they're going to hurt. We have to watch out, for dysrhythmias and heart failure, everything that a open heart surgery entails. Okay. Now there's 2 types of valves. Now see, I was trying to get sneaky, and I'll give you what those 2 things were, the 2 types. So what's one kind of valve replacement?
Mechanical.
Okay, mechanical. What's the other one?
Biological.
Okay, so let's talk about biological. What are the benefits of having a biological heart valve?
Because you're not introducing something mechanical into the body, it may have a better chance of working because it's like natural.
Okay, that's one way.
It
What's
doesn't need
another?
anticoagulants.
Yeah, you don't have to take anticoagulants. Anything else? Okay, now shut up. Okay, so what are the negative aspects of the biological?
It doesn't last for life.
Right. How long does it usually last?
10 to 15 years.
Exactly. That could be a problem, especially if you're 20 years old and you need a valve replacement, right? Do you have to take anti-rejection medications with a valve replacement?
Not with biological.
Right. Well, not with biological. And where are these biological valves coming from?
Cadavers.
Pigs, cadavers, cows are your choices. Okay. And I often wondered, me not eating meat, which way I would go. It's something to think about. Okay. Now let's talk about the mechanical. What is the benefits of the mechanical valve?
It lasts a lifetime.
Yeah, they last a lifetime. What is the negative aspects of a mechanical?
You need anticoagulants for the rest of their life.
Yeah, and what type of anticoagulants?
Coumadin.
Yeah, it's Coumadin, guys. There's no Eliquis for this. Even if you listen to the Eliquis commercials, they'll tell you that it's not good for mechanical valves. Okay, it has to be Coumadin. That's the only one. Now, where's the INR for Coumadin for these valvular problems? For this
2, 3.
What is it? What's the INR?
2.5 to 3.5.
Yes. So it's a little higher, right? It's a little bit higher than what you would, that we usually see is, which is 2.0 to 3.0, right? What are they gonna say? There was something I was gonna say. With these folks, if they come in and they're like, say their INR is 7, we're not gonna sit there and like, okay, let's vitamin K them up, okay? We don't want them, we don't want to do vitamin K because we don't want them to be subtherapeutic and start growing clots. So what we'll do is we'll just let them sit, don't give them Coumadin, and let their body take care of it. Does that make sense? Because we don't want them to get below that 2.5 and then start forming clots. Anytime you enter a mechanical, anything mechanical into the body, whether you're talking about well, you know, like the valve replacements, if you're on the bypass machine, when you're on a bypass machine, we're going to give you a lot of heparin, because that just that element of mechanical, the mechanics, it is so much, it's so dangerous for the patient because they can form the clots. So with mechanical, we have to do Coumadin. So my next question is, what is the anticoagulant overlap? So we're going to do the heparin and Lovenox, right? And then we're going to put them over in Coumadin. Now I want you to consider this. A patient comes in and they need to have gallbladder surgery. We will do the reverse. So we'll take them off of Coumadin and we'll put them on heparin. Okay, the heparin will keep their blood thin enough so that they can have the surgery. So we'll stop it like when they're in pre-op, they'll have the surgery, and then when they come back, we'll put them back on the heparin. Does that make sense? The Coumadin's too long acting, the heparin's so short acting, so we want it to be able to control it better. But they still need to have that anticoagulation. So we'll put them on the heparin drip, we'll stop them when they're in pre-op, and by the time they get back up to us, you know, post-op, we'll put them back on the heparin in therapy.
How
Is that
long
for-
after?
What was that?
How long after post-op will we start them on the Coumadin again?
Well, probably the next day, or even that night, we'll start them back on the Coumadin. But I really want you to hit home that with these guys, we have to keep that blood thin with the mechanical. Okay, we don't want them to be able to coagulate. Sound good?
So right before they're getting ready, if they come in, we'll take them off the Coumadin and put them on heparin.
Right.
And while they're having surgery, they'll have heparin. When they get back, we'll switch them back to the Coumadin. Is that?
No, we'll take them off the heparin when they're in pre-op. So they're not on heparin during surgery, but when they come back up to us, we'll put them back on heparin.
Oh, okay. For at least
until
a day.
Until the Coumadin can take effect again.
Okay.
So like an easy gallbladder surgery for them, for us, you know, which is in and out, it's going to be like could be like 3 to 6 days for them. Because we have to be careful with these guys.
Okay. I didn't mean to say heparin during surgery. That was stupid. Never mind.
No, because we do heparin during surgery when they're doing cath lab or when they're doing open heart surgeries. So it's not stupid, you know, not by a long shot.
So are they at risk though, like during the surgery for bleeding? Because normally
they are, but remember, heparin has such a short half-life that by the time they get into surgery and start cutting, the heparin's already almost out of their system.
And even then, the benefits would outweigh the risk.
Right.
So would they have to be off of Coumadin for a certain amount of days before the surgery?
Well, they want their INR back down to normal. So their INR would be below 2. And that's what we do. We'll do daily INRs until it gets down to 2, and then they can have their surgery.
Okay.
I mean, it really will. I mean, it's a process. Let's just say it's a process. We had one guy, I think he was getting a colonoscopy or something, and he was mitral valve. So we had to wean him off of it and then get him started back up. It was, I mean, it was a great patient. I mean, because you weren't doing anything for him. He was just kind of like chilling like Magellan, until his INR came down to where they could do the colonoscopy. Okay, so how are we feeling? We feel good. Oh, we feel so good.
What was number 14? Which is the most invasive?
That would be the repair or the replacement.
Valve replacement.
Yeah, the valve replacement.
And you said mitral valve prolapse is the most common valve disorder? Okay.
Yes. And the mitral valve is the most common for any kind of problems. Mitral valve and then aortic.
What was number 9 again?
Hold on, my paper's all messed up. Why could dysrhythmias be a complication? Because the heart's working hard and it's not getting what it needs to get done. So the atrium is going, but it's not getting anywhere. So eventually the SA node is just gonna kaput, and their patient's can go into AFib. With the ventricle, it's going. It's pushing, it's trying, but it's kind of like with that AFib RVR, it's going, but it's not having enough cardiac output. So eventually that pacemaker in the ventricle flips out also, and then you can go into VTAC, VFib. The heart just gets frustrated. And that's one way. I mean, I'm sure there's something with the sodium channels and the potassium ions and all that, but to me, they get pissed. And so they act like little 2-year-olds and go off the handle. So they'll go into AFib or they can go into VTAC, depending on what's going on with the heart. But that's why they can go into dysrhythmias. How's that sound?
Sounds good.
Number 10, can you tell us that again? Or me?
How does a thrombus form or become a problem? Because of the fact that if the atrium, I'm like up here, you can't even see it. So if the atrium's pumping and the blood's going down, but then coming right back up, regurgitating, that's not being able to get rid of all that blood in the atrium. Because it's not able to get rid of all the blood in the atrium, what's going to happen? But it's going to coagulate, and a thrombus will form. Same with the ventricle. Okay, if it's not able to get all the blood out of the ventricle, a thrombus can form in the ventricle.
So basically, what you said for number 9. A minute ago.
Yeah, similar, but the only thing with the dysrhythmia is it doesn't have to deal with. I mean, with the thrombus itself, but by the atrium working so hard, not able to push the blood out, it could cause a thrombus.
Okay.
So these folks are going to be on Coumadin till we can fix them. Okay, so we all going to get B's on this test. A couple of you might have to suffer and get A's. Emily's like, I'm not going to suffer.
I want to be in the A group.
I'll take a B. I'm okay.
Okay. So you're going to like it a lot better because it's on paper. Okay. So I think you're going to be a lot happier.
10 questions, right?
10 questions.
Is it multiple choice or short answer?
Oh, girl, you know I don't do short answer. I'm too lazy for short answer. And then I'll have to sit there and read it all. Yeah, I got no time for short answer. I'm going to go zip, zip, zip right through that darn machine.
And then what are you lecturing on tomorrow, Becky? It was the fast.
we're gonna talk about PVD and PAD, so peripheral vascular disease. Okay, so it's the last thing. The only reason I want to do it in person is because it gets confusing at times. So I'd rather just do it in person. That way you don't get so confused. It's not that hard. I don't think it's that bad of a concept, but I think it can be confused. So that's what we'll be lecturing on.
So then the test is over heart failure, this, and then the PVDs.
Yes. Which you should be pretty good with the heart failure and this, studying for the quizzes. The only one is PVD, and I'm going to be working as soon as we get off here. I'll be working on that study guide so that you'll have it for tomorrow.
Will anything respiratory be on the
No
test?
respiratory will be on there. No respiratory. I know I had that things to do list, but I'm trying every Sunday to let you know what's going on for the week, just so we're staying in contact. So respiratory will start next Tuesday. It's not
I
as
appreciate that.
exciting as cardiac, but what can I say? I'm a cardiac kind of queen. I like my cardiac. If we could do 8 weeks of just cardiac, oh, we would have fun. We would have so much fun. Okay?
Is there a PowerPoint thing we have to do?
Yeah. It's for your clinical groups. And I should have done it today. So I'll give you your subjects next week in clinical. It's not that big of a deal. Trust me on it. It's a PowerPoint, and we're going to talk about pediatric cardiac and respiratory anomalies.
Is it worth points?
Yes, it's worth points.
Thank you.
So what I did before is I had 5 points for presentation, and then to make you guys and I uploaded it. So you gave me your presentation. We uploaded it onto Canvas for your clinical group. You watched the PowerPoints, and then you watched the PowerPoint presentations, and then we had a quiz to give, and that quiz was worth 5 points. Okay, so I said it's worth 5 points, but it's actually going to be worth 10 because you're going to have a quiz. And the quiz that you're going to take is open book, open note, open PowerPoint. And it's not nursing questions. It's kind of like the Trotology of Flow has 4 different aspects. What are those 4 different aspects? So it's more like Columbus sailed in 1492 type of questions. Okay, it's not nursing, what you guys are getting used to kind of questions, like which is the best answer. Okay, sound like a plan? And the only reason I do that is so you guys have to watch each other in your PowerPoints. I figure it's a good, and they don't have to be long, 5 minutes. So, but I'll give you all that. Sound like a plan?
Is this the same thing that we did back in January with groups?
Yeah, but it's not with groups.
Okay. I have no memory of obviously I did one of them, but I don't remember which one I did.
Oh, good.
Okay.
It'll be all new to you then. Okay, we good? Okay, I'll see you tomorrow in the flesh. Bye, guys. Have a good night.
Thanks,
Becky.
Okay, thank you.
Becky,
Thank you.
Yeah.
Becky.
Yeah.
So I know you said about for like people who are ordering t-shirts. If we order them, when are they coming in? Are they going to be in by the time break comes?
I'm trying to get them in before Thanksgiving. But if I don't, they'll be in before we leave for Christmas break.
Okay, and how is that working? So are we having to come back to campus? Because when I talked to the school today, are we coming back for the final or once the 30th, are we done?
I haven't decided what I'm doing yet. I just found out
Okay.
today that we could possibly have the final on paper
Okay.
versus Zoom, but I haven't decided yet.
And will you do a study guide for us before the final?
You're killing me. What I would
I
do,
love you.
yeah. What I've done in the past is put out. So I put out a guide of what information will be on the final,
Okay.
and then we go over that guide. It's not like questions like this though, because
No,
you're
but just at least so we kind of know where or guide ourselves
funnel
to what we
yourself.
need to.
Yeah, that's what I've done in the past.
Okay. I'm
Okay.
good with that. Mm-hmm.
Okay. Well,
All
I'll
right. Thanks.
see you all tomorrow.
All right. Bye.
Bye. If I can figure out how to stop this.
Hey,
What?
so for whatever reason on that email, I could not pull up or download where you had, I can only download what I had sent to you. I couldn't see where you had put your comments on it.
Oh, okay.
That's what I was trying to say.
Oh, I thought you said, okay, so what I might do is just send it to your regular email. It seems like if I send it back via Canvas, it never works. So
Okay.
let me see if I can't. I should have your email address. So I'll just send it to your regular email.
Okay.
Because that happened with Jaden too. Was it Jaden? Maybe it wasn't Jay. I don't know. Maybe it was Melissa. I don't know. Somebody, but I sent it through a Canvas and it just didn't work. So I'll just do it via email.
That's fine.
Okay.
Okay.
Yep.
Okay.
I think I'm okay.
I'm gonna grab something to eat and then I'll work on that.
All right. It's no rush. I just didn't see it. I'm always curious what you got to say.
Well, the biggest thing I said this time was, oh my God, you had a lot of mistakes, like grammar and
Really?
yeah.
And that's the problem because I literally have Grammarly, like that's the main, for whatever reason, when I download it on my phone, that's the main thing the main keyboard that I use. So I don't know. It was 3